So basically what I hope to do in the next 20 minutes is to quickly go over what we know about primary prevention of intimate partner violence. And you'll see shortly that I'm going to link that into children's exposure and then provide you with a framework, and I hope we'll have time for discussion. You can give me your thoughts. And then I want to give you an example of an intervention trial that my colleagues and I are conducting. So first of all, and I'm starting from the place that all of us together at the conference have been exposed to lots about definitions, and so I'm not going to, for example, go through the definition of intimate partner violence. I'll just say that some people refer to this as domestic violence. There are lots of different terms for it. Some people focus on violence against women. But in looking at what we know, most of the efforts to date have been aimed at preventing intimate partner violence against women by men. So, we also need to acknowledge that there's partner violence against men and there's same-sex partner violence. And then just to emphasize, and this comes into part of, at the end of the day, we have to make recommendations. And we know a lot about risk, but much of it comes from cross-sectional studies. And I think that we don't make enough distinction between what are referred to as time-varying risk factors, and particularly those that are causal. So I think we need to do a much better job of identifying what are causal risk factors. Now, within primary prevention, so looking at, do we know, starting from the place of trying to prevent partner violence from happening, so from a universal perspective, do we know any programs that work? Much of it has focused on dating violence. And I just want to be clear, dating violence per se is not my particular area. I have defined dating violence up here just because it is different from partner violence. Some people consider it a type of partner violence, and most of the efforts in this area have been directed at school-based and community-based interventions. So, and I'll say more about those shortly, but basically educational type interventions. And just to make the point that dating violence, as you can see on this slide, is very common, and both in terms of victimization, so the 1 in 4 is reporting being victimized, and in terms of perpetration. So this is a very quick overview, and because of time I'm not going into a lot of detail, but in terms of what we know about prevention of dating violence, there are 2 systematic reviews, and they actually reached conflicting conclusions. So the earlier one, Whitaker, really identified 2 programs, Safe Dates and the Youth Relationships Project, and reported that there were positive changes in behavior. So this is a really important element, and I think it relates to the topic of the whole conference. What do we choose as outcomes in measuring the effectiveness? And I would suggest to you that things like attitudes are very important, but they're not the same as the actual reduction of violence. So Whitaker identified these 2 programs, but said that there were limitations because they didn't identify a lot about mechanisms, and they were limited in terms of their generalizability, or what others refer to as external validity. Then Falmouth, who did the more recent review, conducted meta-analyses, and in putting all this information together, concluded that there was no evidence of an effect. So here we've got one systematic review concluding that there is, and another that there isn't. Now, of note, and Falmouth pointed this out, it wasn't possible to include the results from what has been identified as one of the most effective programs. So we've got a real limitation here. So I would characterize this as promising in terms of what we know about being able to prevent dating violence. So, because I'm in the UK, and in terms of identifying gaps, I wanted to use I believe what's called a tube analogy in discussing some of the public health gaps in epidemiology. So you heard me begin by talking about partner violence, and then I talked about dating violence. And we know that, for example, dating violence puts individuals at risk for subsequent partner violence. Most people, or a lot of people, think of partner violence as being violence that occurs in adulthood, whereas dating violence is more about the teen years or adolescence. But we don't know a lot about the mechanisms. So I would suggest to you that that's a really important area for future research. Now, this is a framework coming from, as a past member of what's called the Canadian Task Force on Preventive Healthcare, and indeed something called the US Preventive Services Task Force. They use an analytic framework to try and identify the evidence that we know at different pieces. So, for example, I've got adult women over there. So what do we know about identification, intermediate outcomes, final health outcomes, and then in terms of intervention? So what do we know about what does more good than harm? I would just say to you that around this whole issue of primary prevention, many people have conceptualized it as focusing on identification, and in particular screening. But the truth is, that's really identifying people, for the most part, who've already been exposed. So it's no longer primary. It doesn't mean it's not important. But interestingly, and perhaps I do have a conflict of interest here, at least I need to describe it to you, around the screening evidence. There have been 2 randomized trials, one of which we conducted, that showed no benefits of screening. Having said that, the US, and I'm from Canada, is moving ahead on implementing universal screening, which is perhaps another issue for discussion. The concept of case finding, just to make that distinction, is when questions about, for example, partner violence are incorporated within the context of history taking, a diagnostic assessment, for example, as opposed to a systematic approach of asking everybody the same questions regardless of why they present. So I show you this, and this is typically what people put up in terms of the whole area of prevention. But what I'd like to suggest to you, and this is actually my main point of the presentation, is that understanding the links between children's exposure to maltreatment, including partner violence, and I'll say more about that in a moment, and dating violence and partner violence. And we heard, for example, from Charlotte yesterday in the session about the importance of integration. I think this is really going to hopefully help us in terms of learning more about primary prevention. I just want to say, with regard to child maltreatment, because I work in both child maltreatment and partner violence, a number of us consider children's exposure to intimate partner violence as a 5th type of maltreatment: physical abuse, sexual abuse, neglect, emotional abuse, and exposure to intimate partner violence. Now, there are challenges around that, and in particular, it's very important that women not be blamed for the abuse that their children experience. Having said that, the effects that children experience when exposed to partner violence are very similar to other types of maltreatment. And then this you're all familiar with. Sorry, I'll just back up so you can see that quickly. But it's to make the point of the multi-level overlapping risks. And again, allows me to emphasize again that many of these factors are known to be associated. We may even know about the temporal relationship, but the essence of causation is often not understood. So you can see here, and again, this comes from the WHO World Report on Violence and Health, and has been shown and referred to during the course of the meeting. So now what I'm going to do is turn to a project that we are conducting to give you an example of how we need to think about prevention of partner violence more broadly. And I want to show you how within the same model we're actually trying to conceptualize what we would refer to as primary prevention. And here I'm talking about it as preventing violence before it happens, as well as what others might refer to as secondary or tertiary prevention. Now, how many are familiar with the nurse-family partnership? Okay, a little less than half the room. So, in fact, it was referred to this morning. It's an evidence-based home visiting program that's been evaluated in 3 randomized trials in the US. As you can see here, it's a targeted program, focuses on first-time socially disadvantaged moms, begins prenatally, and it's a very intensive program, focuses on these aspects. And these are the 3 randomized trials, started in Elmira, New York, second one in Memphis. The third one in Denver is particularly important because there was a lot of emphasis within the US context on visits by paraprofessionals. So David Olds did a randomized trial comparing nurses, paraprofessionals to a control group, and found that paraprofessionals had effects that were about half the amount of the nurses. And so after that, David Olds and colleagues said within, and I want to be clear here, the high income setting, nurses are what need to be involved in the application of the NFP. So what happened there was that with the NFP, it was recognized that when there were high rates of partner violence in the home, the benefits on preventing child maltreatment washed out. So this particular program has been shown to prevent child maltreatment, and David contacted our group to look at what can we do about partner violence. Now, interestingly, and this is why it's important to measure it, in the meantime, the NFP was being implemented in various settings around the world, although David's very clear, the NFP cannot go to another country that is quite different from the US without undergoing a randomized trial. So it was implemented in the Netherlands. Now, they didn't choose prevention of partner violence as a primary outcome, but interestingly, they did measure it and found reduction in partner violence, as you can see here. So you can tell we've got various findings coming together. We've got the NFP evaluated in the US and showing that when there are high rates of partner violence, the benefits on child maltreatment wash out, coupled with, and you can see 2013, very recent reports of reduction in partner violence without any particular focus on partner violence beyond what was in the original NFP, and it was very, very minimal. So what we've been doing is we realized, and this again brings up the issue of how do you conceptualize what's required in terms of the rigor of design to evaluate a particular program. And in this case, we wanted to focus on prevention of partner violence within the NFP, but we wanted to make sure that we didn't take away the benefits of the NFP. So we thought that was very important. So we started off and did a multi-site case study, basically a lot of qualitative work in the US, where we interviewed women involved in the NFP, those exposed to violence, as well as nurses and stakeholders, to understand from them what did they think would make a difference and with respect to the NFP. And we did this through individual interviews with clients for safety reasons, focus groups with nurses, and that helped us develop the actual intervention, or as we refer to it, the curriculum. And this shows some of the main components, and for those of you who are interested, we've published the details of the development of this particular intervention in BMC Health Services Research. So big focus on nurse education, we have a manualized intervention, supervisor guidelines. We also developed what's called a site readiness checklist. In other words, the surrounding community, what does it offer in terms of referrals, for example, and the importance of coaching. So we developed this model, we piloted it, and then going back to the main thrust of my talk, primary prevention, we hoped by introducing this that we could help the clients involved in the NFP understand the importance of healthy relationships. So we would prevent violence from happening in the first place, so a form of primary prevention. we would help identify when it is occurring and prevent it from continuing. And we would also try and prevent children's exposure to it. And what we'd love to do, and we don't know if this is effective or not, I want to be clear about that. And in fact, we're doing a randomized trial. We've got one more year to go. We did a cluster-based randomized trial where basically 15 sites were randomly assigned to either the existing NFP or the modified NFP with the intimate partner violence curriculum embedded in it. And by the end of this, we hope we'll be able to identify whether this leads to improvements in the various outcomes that I talked about. And this just shows you, the red dots show you the various sites across the US where this is happening. And we've also, about a year ago, started a randomized trial of the NFP plus this curriculum in Canada, a province-wide trial. Now you might say, well, why did you include it there? We don't even know if it works or not yet. Canada doesn't have the NFP, and the initial information that we received, the qualitative information, and the information from nurses and supervisors in the field is that they feel so much better qualified to address this. But we're being very careful in how we measure the different outcomes associated with it. So this was a big decision. The other thing that led to this is, in the meantime, the US had something called the Affordable Care Act brought in, which meant that screening was being promoted across the country, and referral to counseling. And I think all of us know, what does referral to counseling mean? So now we have NFP sites asking for the intervention, and we say, we don't know if it works or not yet. You're just going to have to hang on. But we're trying to get this information as quickly as we can, and it does underscore some of the challenges in doing an RCT where you're trying to hold other things constant and yet life intervenes. I just want to make the point about research evidence and how we all think about it, and how I think we need to help each other look for biases. And this is what my colleagues and I with NFP certainly try and do. And you can see here a quote from Greenhalgh and Waringa. Research evidence may be used instrumentally and rhetorically to back up particular value-based positions. This occurs particularly when there is high issue polarization, that is, disagreement among stakeholders about what the significant problems are and how they might be addressed. So in addition to interviewing stakeholders in building the intervention so that we would know what the intervention required from a developmental perspective, it's also important to bring people in from the beginning. In what, in Canada, we're tending to use the phrase knowledge translation, because we do get this polarization, and it's important to identify, as I said, those biases at the beginning. So when we think about research practice policy gaps, and I am going to end with what I hope are some solutions, you know, all of us, we want to see violence prevented. I'm a clinician as well as a researcher. I work with families, and you know, I feel the need to do something. But you have heard through the course of this meeting that doing something isn't always better than doing nothing. But there are also resource issues. And by the way, I mean, the Nurse-Family Partnership, when you look at it, it's a very intense program. People in Canada have said it's very expensive. But there also are studies showing that it actually saves costs within a setting such as the US over the long term. We'll need to see if that is also the case in Canada, if indeed it is effective, if we see similar results. And I would just say to you that especially with a primary prevention model, I think we need to measure harm. And harm isn't just looking for harm within the outcomes that you've selected to try and identify benefit. It's actively thinking about what are the potential harms. And for the screening trial that we conducted, we actually developed what's called the COST. It's a consequences of screening tool, because we wanted to actively look at that. So my last slide, looking ahead, and approaches to finding solutions. And, again, this really, I think, is reflected in what you've heard through the conference. I think collaboration is so important. We need to learn from each other around, obviously I'm talking about primary prevention right now, and hearing what the clients involved in the NFP had to say, we felt was just so important. The interdisciplinarity, and I'm a pediatrician and psychiatrist, but on our team we have an epidemiologist, we have a nurse researcher, we have people with a background in social work, so it's really bringing together people of different disciplines. And the NFP is a complex intervention, so they are, that type of intervention is tough to measure in terms of its effects. But most important, if you take nothing else away from what I've had to say today, I hope you will see how, in what I talked about earlier, bringing child maltreatment, dating violence, and partner violence together, we need to think about how these programs could actually address similar types of outcomes, and we need to think about the overlapping risks and protective factors. And Rachel did such a terrific job at referring to that yesterday as well, so I was thrilled to hear you talk about that. Thank you very much.
Okay, thanks.